I want to talk a little bit about something called intermittent auscultation. You see them putting monitors on somebody's belly, and that is going to happen for everybody as you get admitted to the hospital. That's A-okay, that's evidence-based. We want to make sure baby's doing well with contractions. It's a real easy way to just get an idea of how baby's doing with basically just an NST. But there is something you can use called intermittent auscultation if you are low risk. That means no epidural, no like magnesium, no induction, nothing like that. It's just for low risk patients. Now let's talk a little bit about what intermittent monitoring looks like. It is where they use the Doppler, which is the same thing your provider uses in the office. It's just that little wand, and they use that to listen to baby. Now they're going to start before a contraction. They're going to feel your belly while you have a contraction, and then they're going to monitor the baby after it. They need to do that either it's like every hour to 15 minutes to 5 minutes while you're pushing. So somewhere in that range, the hospital is going to have a policy on how often the nurse needs to do it based on where you are in your labor. Of course, with continuous fetal heart monitoring, they have an ultrasound circle and they have a TOCO, which monitors contraction circle, and both of those are monitored continuously. Now with the intermittent auscultation, you have the ability to move around while the nurse isn't in there. And so a lot of people really like that. The people I've talked to who have used intermittent auscultation really liked the movement that it allowed them. Now, the one thing that I think might bother some people, especially if you were trying to get rest, is that nurse has to be in there every 15 minutes, touching your belly, watching the baby, all those different kinds of things. So that's something to think about. What does the data show? There was a Cochrane study that took lots of different studies and pulled out similar themes. It showed there was an increase in spontaneous deliveries. So that means less C-sections, less operative deliveries, which would be a forceps or vacuum, which we talk about in this chapter. So that's great news, right? It shows that when you're looking for something to be wrong, like we sort of are with continuous fetal heart monitoring, we will find it, and it ends up causing maybe more C-sections than we need to, because it also showed there were no changes in neonatal mortality, so that's babies who died, or cerebral palsy, which is the main reason that we started using continuous fetal heart monitoring. They thought that it would help us be able to see when babies were having problems and assist when needed. Now, it did show there was a small increase in neonatal seizures, so that's something you need to consider. They didn't do long-term studies on those babies that had the seizures, because just because a baby has a seizure doesn't mean it is a long-term issue for that baby. So I took a class on this at a recent conference I was at, and while I was at it, I was thinking that it may also help just decrease birth trauma in general, because as we're looking for things, we're gonna find the baby's heart rate dip. And then 5 nurses run in your room. They're going to increase your IV fluids. They're going to turn off the Pitocin. They're going to turn you to the side, and they may ask to check your cervix. So a lot of people find that very traumatic. And when we're not monitoring baby all the time, we're less likely to find that. And I just want to be really clear that if we monitored any baby 24/7, we're going to see times where the heart rate dips down. Now that may be the baby grabbing onto the cord. It may be that the head's in a wonky position, or it pinches off the cord for a minute, and then good old Wharton's jelly slips the cord out of that area. But I want you guys to know that we would see dips in heartbeats for all babies out there, you and me included, and we turned out okay, right? Babies are made to have those dips in heartbeat. The question is if it's a big problem and it's something that we need to solve. Now, ACOG, which is the Association of Doctors in the United States, and AWHONN, which is the Association of Nurses in the United States, actually both recommend it for low-risk deliveries, but it is not the standard of care in most hospitals in the United States. I haven't done it. I never did it at the hospital that I most recently worked at. I did it at the one before that. We had midwives and they would often help us with it. But I don't know if I've even seen the policy of it. What our hospital turned intermittent auscultation into was an NST every hour, which is not the same as intermittent auscultation, but it does still give you the value of some movement included. Now, why do hospitals still use continuous fetal heart rate monitoring? The number one I've got to guess is legal. They think that it covers their bum if we're watching the baby all the time. Parents can't show us that something was wrong. Some of it may be staffing. I can watch my patient's heart rate in the other room and not actually be in their room, but know that things are okay, versus if I have to go into your room every 15 minutes, it's going to be more difficult to have 2 patients in that situation. And we know the hospitals love their money. Now, I also think the patients want this. They want to see baby monitored all the time. They think that that is the standard of care because that's what everybody's had. So patients wanting it makes the hospital want to provide it, right? And ultimately, the hospital sort of just opts everyone into high risk sometimes, which I don't love. But in this situation, that's sort of what we're doing, because ACOG and AWHONN are saying if you're low risk, they would recommend doing this. But hospitals have decided, no, we're just going to continuously monitor everybody. And I'm not saying that one is right for everybody. The changes in all of this were really small. So if you're like, I would really like to see how baby is doing, I know I've had patients who, once I get the baby on the monitor, feel a lot of relief because they worried their whole pregnancy the baby wasn't doing well. So they love that we're monitoring the baby. So either one's going to be up to you. I just love that I'm giving you guys this option. Now, I think this is really important to talk with your provider about. Ask them if they do it at the hospital. Again, the last hospital I worked at, nobody ever did this. And so if you went in saying you wanted intermittent auscultation, you would get a lot of pushback from the nurses because they simply don't know how to do it. And it actually involves different charting than we would do on continuous fetal heart monitoring, which is like a whole other bag of chips with the charting systems. So talk with your provider, ask them if they've seen it ever done at the hospital, if they're comfortable with you doing it, and if the nurses are comfortable doing it. Now, if he's like, they do it from time to time, but I do see a lot of pushback, what I would recommend is putting it on your birth plan that you would like to try intermittent auscultation. And I would also mention that you've read the Cochrane analysis, actually read it if you want to, showing that you understand the risks and the benefits of this so that the nurse doesn't need to go over it in the hospital. Of course, as we're monitoring the baby, if we see any issues, we're going to switch to continuous fetal heart monitoring, right? If we're watching the baby and the baby's heart rate dips a little bit after a contraction, we're going to switch to the continuous heart monitoring to monitor baby better. So at any point in time, if we see any issue or all of a sudden you decide you want IV pain medicine, they want you to be on continuous monitoring for a little bit, we will switch to continuous monitoring for that. The good news is that whatever type of monitoring you end up having during delivery, you can use what you're learning in the online prenatal class for couples to make it work for you. It showed that there was an increase in C-sections for people who had continuous monitoring, but because you know how to talk with your provider about possibly waiting to do the C-section or other options that you can have, you're going to do great with either type of monitoring. I just wanted to let you know that intermittent auscultation was an option, and you can ask your provider about it in the office. And I will say, I had a really hard time with this because it's not something I'm comfortable doing. So if a patient came in and said they wanted intermittent auscultation, I would be super nervous. Again, nurses don't want to lose their license and they want to provide the best care for you. So just make sure that you're checking with your provider and that everyone has a comfort level with it. And I think you're going to do great.